So now we'll be talking about the antimicrobial therapy, which is microbial tuberculosis isoniazid. So in case of prophylaxis with isoniazid, treatment with RIP for treatment, that is rifampicin, isoniazid, pyrimethamine, and ethambutol. MAV intracellular prophylaxis azithromycin or rifampicin, and the treatment would be azithromycin or clarithromycin plus ethambutol. Can add rifabutin or ciprofloxacin. Lepre no prophylaxis, but long-term treatment with dapsone and rifampicin for tuberculosis and clofazimine for leptometastasum. So isoniazid inhibits the mycolic acid formation, arabinoglycan, the ethambutol inhibits the arabinoglycan galactan synthase, that is inhibits the ethambutol inhibits the arabinosyl transferase. The next we have is the rifabutin and rifampin, which inhibits the DNA RNA polymerase, and we have the pyrimethamine, which is industrial nuclear mechanism. Okay, so next we'll be talking about the rifamycin, that is includes the rifampin, rifabutin, and rifampicin. So it inhibits the RNA polymerase, clinical use in microbial tuberculosis, delay resistance to dapsone when used for leprosy, used for meningococcal prophylaxis and chemoprophylaxis in contact with children with influenza type B. Adverse effect of rifampicin is minor repository drug interaction, increased cytochrome P450, orange body fluid, known as a side effect. Rifabutin favored over rifampin in patient with HIV infection due to less cytochrome P450. So rifabutin is given in HIV. So mutation reduces the drug binding to RNA polymerase. Monotherapy rapidly leads to resistance. Okay, so 4R, that is RNA polymerase inhibitor, ramp of microsomal cytochrome P450, red orange color urine, and rapid resistance if used alone. So we have the next isoniazid, decreased synthesis of mycolic acid, bacterial catalase, peroxidase encoded by CAT gene needed to convert INS to active metabolite. Clinical use in mycobacterium tuberculosis, the only agent used for solo prophylaxis against TB and also used as a monotherapy for latent TB. So adverse effect is hepatotoxicity, cytochrome P450 inhibition, and drug-induced SLE, anionic gamma metabolic acidosis, B6 deficiency, peripheral neuropathy, sideroblastic anemia, seizure in high dose refractory to benzodiazepines administered with B6. So INH injuries, nephrons, and hepatotoxic resistance co-mechanism which is due to underexpression of CAT. Next we have the pyrazinamide, that is mechanism on this in clear. Benzamide is a product that is compared to active compound pyrazinoic acid, works best at pH, post-phagolysis, clinical use in microbial tuberculosis. Adverse effect includes hyperuricemia, hepatotoxicity. Ethambutol mechanism is decreased carbohydrate polymerization of microbiome cell wall by blocking the arabinosyl transferase. Is clinical use in microbial leprosy, causes optic neuropathy, red, green, orange blindness, usually reversible. We have streptomycin, interface with 30S ribosome component, and is microbacterium tuberculosis, tinnitus, vertigo, ataxia, and nephrotoxicity. So we have the antimicrobial prophylaxis. Exposure to meningococcal infection, we give ceftriaxone, ciprofloxacin or rifabutin. High risk endocarditis undergoing surgical or dental procedure, amoxicillin. History of recurrent UTI, TMP, SMX. Malaria prophylaxis for travelers, atorvaquine or provaquine, mefloquine, doxycycline, primaquine or chloroquine for areas with sensitive pregnant patient with carrying group B streptococci, intrapartum penicillin G or ampicillin, prevention of gonococcal conjunctivitis in newborn, erythromycin ointment in eye, prevention of post-surgical infection due to asorius, cefazolin, vancomycin if positive for MRSA, prophylaxis of strep pharyngitis in children with rheumatic fever, benzathine, penicillin G or oral penicillin B. If CD4 count is less than 200, then TMP SMX for pneumocystis pneumoniae. If CD4 count is less than 100, TMP SMX for pneumocystis pneumoniae and toxoplasmosis. So treatment of high resistant bacteria. So MRSA, vancomycin, daptomycin, linezolid, tigecycline, ceftriaxone, and doxycycline. VRE, daptomycin, linezolid, tigecycline, streptogrenin, okay, and multi-drug resistance, Pierogenesa, multi-resistance is Acinetobacter baumannii, and polymyxin B and E. colistin. Okay, now we'll be talking about some of the antifungals and the HIV drug, and we'll end up. So antifungals include terbinafine, which inhibits the squalene epoxide to convert from squalene to squalene epoxide. Now we have the azoles, that is from the squalene epoxide the lanestrol is formed, and the lanestrol to convert into ergostrol, the 14 alpha demethylase, which is inhibited by azoles. Okay, and they act here. And similarly, the nucleic acid synthesis inhibitor in antifungal is piocytosine, whereas the cell wall inhibitors is echinocandins, that is beta glycan, that is anidulafuscin, caspofuscin, and migafuscin, whereas cell membrane integrity loss is due to from the amphotericin B and nystatin. So amphotericin B is bind-egrosol unique to fungi, forms membrane pore that allow leakage of electrolyte. Clinical use is serious systemic mycosis, cryptococcus, amphotericin B flow-cytosine for cryptococcal meningitis, blastomyces, covidomyces, histoplasma, candida, mucor, and intrathecal for coccidiocal meningitis. Okay, so amphotericin B supplements potassium and magnesium because of altered renal tubule permeability. So adverse effect is fever, chills, sick baby syndrome, hypotension, nephrotoxicity, arrhythmias, anemia, and IV phlebitis. So amphotericin B also to maintain the hydration, decrease nephrotoxicity. Liposomal amphotericin B decreases toxicity. So we have the nystatin, same as amphotericin B, topical use only as too toxic for systemic use. So Swiss and Salu for oral candidiasis thrush, and for topical for diaper rash and vaginal candidiasis. Flucytosine inhibits the DNA and RNA biosynthesis by conversion to high fluorouracil by cytosine deaminase. Systemic fungal infection, especially meningitis caused by cryptococcus, in combination with amphotericin B, side effect bone marrow suppression. Although cotrimoxazole, fluconazole, isaconazole, itraconazole, ketoconazole, miconazole, and boriconazole inhibit the fungal strol synthesis by inhibiting the cytochrome P450 enzyme that converts the lanestrol to ergostrol. Clinical use in local and less serious systemic typhoid, fluconazole for chronic suppression of cryptococcal meningitis in people living with HIV and candida infection for all. Itraconazole may be used for blastomycosis, covidomycosis, histoplasmosis, sporothrix, and cotrimoxazole and miconazole for tropical fungal infection, voriconazole for aspergillosis and some candida, and isavuconazole for serious aspergillus and mucor infection. Side effects of azoles include testosterone synthase inhibitors like gynecomastia, especially ketoconazole. Liver dysfunction inhibits the cytochrome P450. We have the terbinafine inhibits the fungal enzyme squalene epoxide, dermatophytes, especially oncolysis, fungal infection of finger or toenail. So terbinafine is GI upset, headache, and hepatotoxicity and taste disturbance. So next we have the echinocandidates, that is the anidulafungin, caspofungin, and migafungin inhibit cell wall synthesis by inhibiting the synthesis of beta glycan, invasive aspergillosis and candida. It is used and it is causing the side effect GI upset, flushing by histamine. You have the griseofulvin, which interferes with the microtubule formation and disrupts the mitosis, deposits in the keratin containing tissues and nails. Oral treatment of superficial infection inhibits the growth of dermatophytes, tinea, and ringworm. Griseofulvin, and there is side effects as tetrazoline, carcinogenic, confusion, headache, disulfide reaction, increased cytochrome P450, and warfarin metabolism. We have the antiprotozoal therapy, the pyrimethamine, toxoplasmosis, suramine, and millar-sopor, which is the trypanosoma brucei, nifortimox, that is cruzi, and sodium stiboglutamate, the leishmaniasis. Antiprotozoal therapy, pyrimethamine for toxoplasmosis, suramine and misorpol for toxoplasmosis brucei, nitropyrin for cruzi, and sodium stiboglutamate for leishmaniasis. Antimide louse therapy, permethrin and malathion for acetylcholinesterase inhibitor, topical or over ivermectin, and used to treat the scabies, sarcoptes, scabies, and lice, pediculus, and pethras. Chloroquine is blocks detoxin of heme into hemozoins. Okay, heme accumulates and is toxic to plasmodium. Treatment of plasmodium species other than P. falciparum. Frequency of resistance of P. falciparum is too high with chloroquine. Resistance due to membrane pump that can decrease intercellular concentration of drug. Treatment P. falciparum with the artesunate or lumefantrine or atorvaquine or primaquine. For life-threatening malaria, use quinidine in US, quinine elsewhere, or artesunate. Side effect is retinopathy, pruritus. And the anti-helminthic therapy, the pyrantol palmate, ivermectin, bendazole, microtubule inhibition to treat bend worms. And we have the praziquantel, increased calcium permeability, increased vacuolation, and diethyl carbamazepine. Okay, so the next drug we have having is the attachment inhibitor, the maraviroc, and we have the penetration inhibitor, the infodvetide. We have the integrase inhibitor, the dolutegravir, ilvitegravir, draltegravir, and bistiravir. Then we have the protease inhibitors. All the weird like integrase inhibitor was dolu, ilvi, ralti, and bc. And protease inhibitors are atenavir, darunavir, fosempavir, lopinavir, indinavir, ritonavir, and sequinavir. Okay, and so we have the next as the NRTIs, the avacacivir, okay, lamivudine, zidovudine, tenofovir, okay, and imtricibin. Similarly, NNRTI we have efavirenz, nivaripine, and delaviridine. Okay, so the nucleic acid guanosine analog are acyclovir and vanciclovir. Viral DNA polymerase inhibitor are cidofovir and foscarnet. Guanosine nucleotide synthase are ribavirin. Adenosine analog is remdesivir. Okay, and the endonuclease inhibitor are baloxavir. Release of progeny virus, neuraminidase inhibitor oseltamivir, zanavir, influenza. So oseltamivir and zanamivir. So oseltamivir and zanamivir inhibits the influenza neuraminidase, decrease release of progeny virus. Oseltamivir treatment and prevention influenza A and B, beginning therapy within 48 hours of symptoms, onset may shorten duration of illness. We have baloxavir inhibits the cap snatching nuclease activity of the influenza virus, RNA polymerase, decrease viral replication. Baloxavir treatment within the 48 hours of symptoms and short duration of illness. We have remdesivir, recently approved for COVID-19 during hospitalization. Pro of ATP analog, the active metabolite inhibits the RNA polymerase, which is RNA dependent, and evades proofreading by viral exoribonuclease and decrease viral RNA production. Next we have the acyclovir, famciclovir, and valacyclovir. It's a guanosine analog, monophosphate by HSB and VGP thymidine kinase and not phosphorylated on infected cells. Few adverse effects: triphosphate formed by cellular enzymes, preferentially inhibit viral DNA polymerase by chain termination. HSB and VZV, weak activity against EBV, no activity against CMV, used for HSB induced mucocutaneous and genital lesion as well as for encephalitis. Prophylaxis in patients who are immunocompromised, no effect on latent form of HSB. VZV, valcyclovir, a prodrug for herpes zoster, and use famciclovir. Side effects of acyclovir includes obstructive crystalline nephropathy, acute kidney injury if not adequately hydrated. And we have the mechanism of resistance is mutated viral thymidine kinase. We have the next is the ganciclovir. Ganciclovir is a guanosine analog, 5-monophosphate formed by CMB viral kinases, triphosphate formed by cellular kinase, preferentially inhibit viral DNA polymerase. So basically they are inhibiting these acyclovirs, ganciclovir used for the herpes and all this, so they are used for inhibition of DNA polymerases. Clinical use of ganciclovir CMB, especially in patients with immunocompromised. Valcyclovir is a product for ganciclovir has better tolerability. Side effect includes bone marrow suppression, leukopenia, neutropenia, thrombocytopenia, renal toxicity, more toxic to host enzyme than valcyclovir. Mutated viral kinases is mechanism of resistance of ganciclovir. Next we have the foscarnet, which is a viral DNA RNA dependent polymerase inhibition, and HIV reverse transcriptase inhibitor, binds to pyrophosphate binding site of enzyme, does not require any kinase activation. Foscarnet used in CMV retinitis in immunocompromised patients when the vanciclovir fails or cyclovir resistance SSB. Side effects include nephrotoxicity, electrolyte abnormality, hyperphosphatemia, hyperkalemia, or hypermagnesemia can lead to seizure. Mechanism of resistance is mutated DNA polymerase. We have cidofovir, preferentially inhibits the DNA polymerase, does not require phosphorylation by viral kinases. Cidofovir is very down, and cidofovir and foscarnet do not need the thymidine kinase. Okay, and cidofovir used in CMV retinitis in immunocompromised patient or cyclovir resistant SSB. Side effect of cidofovir is nephrotoxicity, coagulation with probenecid, and IV saline to decrease the toxicity. So now we have the HIV antiretroviral therapy, often initiated at the time of HIV diagnosis. Strong indication for use with patient predisposing with AIDS defining illness, low CD4 count and less than 500, or viral load. Regimen consists of 3 drugs to prevent resistance to an RTI and preferably integrase inhibitor. Most RTIs are active against HIV and HIV2, exception NRTIs and not effective against HIV2. So NRTIs and infurbated not effective against the HIV2. So when you talk about the NRTIs, okay, completely inhibit the nucleotide binding to reverse transcriptase and terminates the DNA chain. Tenofovir is a nucleotide and other are nucleoside. All needs to be phosphorylated to be active. Zidovudine can be used for general prophylaxis and during pregnancy and decrease risk of fetal transmission. Bone marrow suppression can be reversed with granulocyte proliferating factor, CSF, and erythropoietin, peripheral neuropathy, lactic acidosis, and anemia with the zidovudine. Avacyclovir contraindicated patient with HLA-B5701 mutation due to increased risk of hypersensitivity. NRTI binds to reverse translated different site from NRTI, do not require phosphorylation to be active or competent with the nucleotide. Rash, hepatotoxicity are common to NRTIs. Vivid sense in a symptoms are common with efavirenz. So we have integrase inhibitor, inhibits HIV genome integrase into the host cells chromosome by reversibly inhibiting the HIV integrase, includes creatine kinase. Next we have the protease inhibitors, which is assembly of the virion dependent on HIV protease whole gene, which cleaves the polypeptide products of HIV mRNA into the functional part. Thus protease inhibitors prevent maturation of the new virus. Ritonavir can boost other drug concentration by inhibiting the cytochrome P450. Hyperglycemia, GI tolerance, lipodystrophy, Cushing-like syndrome. Rifampicin and potent CYP UGT inducer reduces protease inhibition concentration. Use rifabutin instead. So entry inhibitor are influenza that bind to GP41, inhibits the viral DNA. So the skin reaction at the injection site. Influenza inhibits fusion, whereas maraviroc inhibits ROCK, that is bind the CCR5 surface T cells. Monocyte inhibit the integration with the GP120. Now we have the last the antimicrobials and its antibiotics: sulfonamide, corticosteroids, amylase, autosurrogacy, fluoroquinolones, cartilose, damage, clarithromycin, embryonic toxicity, tetracycline discoloration, inhibition of bronchogrowth, rifavirin causes and grisofulvin causes teratogenicity, chloramphenicol, baby gravis syndrome. Now disinfection and sterilization. Goal includes the reduction of the pathogen organism counts to be safe, disinfection, and the inactivation of all the microbes including spore is sterilization. As for sterilization, so autoclave is pressurized distinct greater than 120 degrees. Sporicidal may not relatively inactive prions. Alcohol denaturate protein and disrupt cell membrane, not sporicidal. Chlorhexidine disrupts cell membrane and coagulates intracellular cellular component. Chloroquine oxidase and denaturates protein and is sporicidal. Ethylene oxide alkyl and is sporicidal. Hydrogen peroxide is sporicidal. Free radical oxidation. Iodine iodophores are maybe sporicidal. Halogenation of DNA, RNA, and protein. Quaternary amines are impaired permeability of cell membrane, not sporicidal. So next we have the drug for hepatitis C therapy. Chronic hepatitis C treated with multiple therapy that target specific step with HSV replication, HSV encoded protein. Okay, so we have the NS5A, NS5B, and NS3/4A, and we have the alternative drug for hepatitis C therapy is ribavirin. So ribavirin. Okay, so now A is Asvir. Okay, so lady pasavir, bitsavir, and veldpartsavir. Okay, Ovir, A for Asvir. Okay, so inhibits NS5A, a viral protein that plays a key role in RNA replication, headache, and diarrhea. NS5B is सोफामा बस्ने बोडीहरू हैन, बी आयो भने सोफोस्बुभिर and dasabuvir inhibits NS5B RNA dependent RNA polymerase. Okay, and a chain terminator prevents viral replication, fatigue, and headache side effect. So NS3/4A inhibitors is Previr. So Granzoprevir and Simiprevir. So from the up to down is alphabetical: Asvir, then Buvir, then Previr. Previr inhibits the NS5/4A viral protease, preventing viral replication. Grazoprevir headache and fatigue. Simiprevir photosensitivity. Alternative drug is ribavirin, inhibits the synthesis of guanosine nucleotide by completely inhibiting the IMP dehydrogenase, used as adjuvant in case of refractory to new medication. Okay, thank you. So now we'll be talking about the antibiotics. In antibiotics, we have the different class working on it. So folic acid reduction, DNA methylation, and reduction is by DNA methylation is working by sulfonamides, that is sulfamethoxazole, sulfisazole, and sulfadiazine. Trimethoprim inhibits the tetrahydrofolate, that is the dihydrofolate reductase, same as by primethoprim. Similarly, we have the membrane integrity of the bacterial cell wall, that is done by daptomycin and polymycin. Daptomycin we give for the gram positive and the polymycin for gram negative. Similarly, we have the petroglycan synthase inhibitors like the vancomycin and bactericin. Okay, so that inhibits what you call the cell wall. And similarly, we have petroglycan cross-linking inhibitors like the penicillin group of drug, oxacillin, nifacillin, and diclocillin, which is palisanase resistant penicillin. We have anti-pseudomonal for peptidoglycan cross-link, that includes the ticarcillin and piperacillin. We have the cephalosporins, and we have the carbapenems and the monobactams, azithrobactam and the carbapenem. Okay, so in the cephalosporin group, we have the first generation cefazolin, second is cefoxitin, third is ceftriaxone, fourth is cefepime, fifth is ceftraolin. Similarly, we have 30S inhibitor like aminoglycosides, which includes gentamicin, neomycin, amikacin, tobramycin, and streptomycin. And we have the tetracycline groups of drug that inhibits the 30S. Similarly, we have the 15S inhibitors, which is chloramphenicol, clindamycin, linezolid, and we have the macrolides azithromycin, clarithromycin, and erythromycin. Similarly, DNA guidase inhibitors, fluoroquinolones includes the ciprofloxacin, levofloxacin, and we have the quinolones like nalidic acid. RNA polymerase inhibitor is rifampicin, whereas DNA integrative free radical damage is done by metronidazole. So now we'll be starting with the penicillin G and B. Penicillin G is IV and IM, whereas penicillin V is oral. Prototype beta-lactam antibiotic. Mechanism is of penicillin G and B is DLR-DLI structure analog. Binds penicillin binding protein transpeptidase. Block transpeptidase cross-linking of peptidoglycan wall and activates autolytic enzymes used in most commonly for gram-positive organism Streptococcus pneumoniae, pyrogens activum, also for gram-negative cocci, mainly Neisseria meningitis. Spirochetes like Treponema pallidum, bactericidal for gram-positive cocci, mainly gram-positive rods, gram-negative cocci, and spirochetes and beta-lactam is sensitive. So they are bactericidal. So hypersensitivity reaction, direct Coombs test positive, hemolytic side effects are hypersensitivity reaction, direct Coombs test, hemolytic anemia, drug-induced interstitial nephritis. So the resistance is beta-lactamase clips the beta-lactam mutation in penicillin binding protein. So the next is penicillin sensitive penicillin. Bacillase sensitive penicillin, which is amoxicillin, ampicillin, amoxicillin, same as penicillin, and wide spectrum penicillin sensitivity, also combined with the clavonic acid to protect the destruction by beta-lactamase. So amoxicillin has a greater oral viability than ampicillin. So clinical use in extended spectrum like H. influenza, H. pylori, E. coli, Enterococcus, Listeria, monocytogenes, Proteus mirabilis, Salmonella, and Shigella. Coverage ampicillin is H. helpis, kills enterococci. So adverse effect of amoxicillins are hypersensitivity and pseudomembranous colitis. Okay, and the resistance is penicinase, that is the type of beta-lactamase cleaves the beta-lactam ring. So penicillin resistant. We talked about the sensitive. Now we have the resistant. So that is beta-lactamase resistant penicillin मा काम गर्ने चाहिँ डिक्लोसिलिन, नेफासिलिन र ओक्जासिलिन भयो हैन. अनि सेम एज पेनिसिलिन न्यारो स्पेक्ट्रम पेनिसिलिन इज रेजिस्टेन्स बिकज bulky R group blocks access of beta-lactamase ring. So this is given for Asorius except MRSA. So their hypersensitivity reaction and interstitial nephritis caused by this penicillin, and mechanism resistance is MRSA has altered penicillin binding protein target site. So MRSA is coming first is the beta-lactamase. For beta-lactamase there was development of dicloxacillin, nafacillin, oxacillin. Now for the MRSA, now we have anti-pseudomonal. So pseudomonas को लागि anti-pseudomonal penicillin we have. For pseudomonas species एकदम स्पेशल बनाएको छ पिपरासिलिन र टिकरासिलिन. नामै P for P को लागि दिने हैन. अनि सेम एज पेनिसिलिन एक्सटेन्सन पेनिसिलिन इज सेन्सिटिभ बट विथ बीटा-लैक्टमेज इन्हिबिटर्स हैन. अनि एडभर्स इफेक्टमा हाइपरसेन्सिटिभ रिएक्सन भयो. सेफालोस्पोरिन को बारेमा अब कुरा गर्नु पर्यो. सेफालोस्पोरिन भनेको बीटा-लैक्टम ड्रग that inhibits cell wall synthesis but less susceptible to penicillin, and they are also bactericidal. So beta-lactam is not going to kill them. So organisms typically not covered in first to fourth generation cephalosporin are lame. So organisms typically not covered by the cephalosporin are lame. That is Listeria. Atypicals are the Chlamydia and Mycoplasma, and MRSA and Enterococcus. The cephalosporin is not covering the Listeria, atypicals like Chlamydia and Mycoplasma, MRSA and Enterococcus. So next we have the clinical use of the cephalosporin. In the first generation we have the cefazolin and cefalin. Okay, cefazolin used prior to surgery to prevent Asorius wound infection. Okay, so used for Proteus mirabilis, E. coli, Klebsiella pneumoniae. So second generation we have cefaclor, cefoxitin, that is like FA, that is arrogant, like okay, cefaclor, cefoxitin and cefuroximine. So similarly we have gram-positive cocci. We have the H. influenza, Antibacterial agination, Neisseria species, Serratia, Proteus, E. coli, and Klebsiella. So similarly, we have third generation cephalosporin, ceftriaxone, cefotaxime, cefodoxime, cefotriaxone, and cefepime. Serious beta-lactam injury, resistance to beta-lactam. So third generation can cross blood-brain barrier. Ceftriaxone, meningitis, gonorrhea, disseminated Lyme disease. Ceftazidime is for Pseudomonas. Ceftazidime, dim is dim dika. So Pseudomonas. Fourth generation is cefepime, gram negative with increase against Pseudomonas and gram positive organism. Fifth generation is ceftriaxone, that is the gram positive. Ceftriaxone is fifth generation, and ceftriaxone covers MRSA, Enterococcus faecalis, and does not cover Pseudomonas. So the side effects of cephalosporin is hypersensitivity reaction, autoimmune hemolytic anemia, disulfiram reaction, vitamin K deficiency, low rate cross reactivity even in penicillin allergic patients, increased nephrotoxicity with aminoglycosides. So mechanism of resistance is a type of inactivated by the cephalosporin, a type of beta-lactam, structural change in penicillin binding protein transpeptidase. So we have beta-lactamase inhibitor like clavulanic acid and avibactam, sulbactam, tazobactam. They are beta-lactamase inhibitors. So clavulanic acid, avibactam, sulbactam, and tazobactam often added to penicillin antibiotic to protect the antibiotic from destruction by beta-lactamase. So CAST is the mnemonic, amoxicillin clavulinate. We have the combination, they are called clavum. We have ceftazidime and avibactam, that is CA combination, that is ceftazidime and avibactam. We have the ampicillin and sulbactam combination, and we have piperacillin and tazobactam combination. Okay. Similarly, we'll be talking about the carbapenems, which is the doripenem, imipenem, meropenem, itrapenem. Imipenem is a broad spectrum beta-lactamase resistant carbapenem, always administered with cisplatin, inhibition of renal dihydropeptidase 1 to decrease inactivation of drug in renal tubules. So carbapenems are added with cilastatin, okay, to inactivate because the carbapenem gets inactivated. So cilastatin inhibits the renal dihydropeptidase 1 to inactivate in renal tubules. So never carbapenem with imipenem kills cilastatin with cilastin. So new carbapenem includes itrapenem, limited pseudomonal coverage, and doripenem. So irtapenem and doripenem are new. So clinical use of carbapenem are gram-positive cocci, gram-negative ropes, anaerobes, wide spectrum and significant side effect limit use to life-threatening infection. And after the drug has failed, meropenem has decreased risk of seizure and increased risk of dihydropeptidase. So adverse effect of carbapenem includes GI distress, rash, CNS toxicity, and high plasma level. So mechanism of resistance is inactivated by carbapenem produced by Klebsiella pneumoniae, E. coli, and aeruginosa. Next we have the azithromycin, which is less susceptible to beta-lactamase, prevent peptidoglycan cross-linking by binding to penicillin binding protein 3, synergistic with aminoglycosides, no cross-allergenicity with penicillin. So azithromycin is gram-negative only, no activity against positive rods or anaerobes for penicillin allergic patients and those with the renal deficiency. We cannot tolerate aminoglycosides. So adverse effect of azithromycin is usually non-toxic oxonal GI upset. Okay, we have the vancomycin inhibition, cellular peptidoglycan formation by binding to DLR portion of the cellular precursor, bactericidal against most bacteria, bacteriostatic against Clostridium difficile. So it is cidal, whereas it is static against Clostridium, not susceptible to beta-lactamase. Gram-positive box only for serious multi-drug resistance including MRSA, S. epidermidis, sensitive enterococci, and Clostridium difficile oral route. So adverse effect because well tolerated in general but not trouble-free, nephrotoxicity, osteotoxicity, thrombophlebitis, diffuse flushing red man syndrome, idiopathic reaction, large preventable by pre-treatment with antihistaminics, and Brust syndrome. So mechanism of resistance of vancomycin includes occurs in the bacteria Enterococcus by the amino acid DLR to DLR-delact. Okay, so you cannot try it with vanco. Okay, now we have the protein synthesis inhibitor. So specifically target the small bacterial ribosome 50-70S made up of 30S and 50S, leaving human 80S unaffected. All are bactericidal except aminoglycoside, which is bactericidal. All are bacteriostatic. Okay, all proteins are statics. Okay, proteins are static except the aminoglycoside, which is cidal, and linozolid is variable. So aminoglycoside is amino group halera, so they side guarding. And 30S is aminoglycoside and deuterosine, 70S is chloramphenicol, clindamycin, erythromycin, linezolid. So macrolides and clindamycin effects in the translocation. Okay, and chloramphenicol 50S inhibits the peptidyl transferase, whereas tetracycline inhibits the tRNA binding, and aminoglycosides inhibit the 30S, will inhibit 50S. So now we'll be talking about the aminoglycosides, the gentamicin, neomycin, amikacin, tobramycin, streptomycin. It is bactericidal, irreversibly binds to ribosome subunit, can cause misreading of mRNA and block translocation. Requires O2 for uptake and therefore ineffective against anaerobes. So clinical use in the gram-negative infection, the aminoglycoside synergistic with the beta-lactam, neomycin for bowel surgeries. So side effect is nephrotoxicity, neuromuscular blockade, absolute contraindicated with myasthenia gravis, ototoxicity, nephrotoxicity. Mechanism of resistance is bacterial transfer enzyme inactivates the drug by acetylation, phosphorylation, and adenylation. We have tetracycline, minocycline, doxycycline, and tetracycline. Tortious trimer prevent attachment of tRNA, amino-acyl tRNA, limited CNS penetration. It is doxycycline is fecally eliminated and can be used in patients with renal failure. Do not take tetracycline with the milk, antacids, or iron-containing preparation because divalent cations inhibit drug absorption in the GIT. Borgeria used for Borgeria burgdorferi, pneumonia, drug ability to accumulate intracellular and make them very effective against rickets and chlamydia. Used to treat acne, doxycycline effective against community-acquired MRSA. Adverse effects include GI distress, discoloration of the teeth, inhibition of bone growth incident, photosensitivity, unavoided in pregnancy and in children except doxycycline. Decrease optical influx of bacterial cell by plasmid encoded transport pump. We have tetracycline, which is tetracycline derivative, binds to 30S ribosome, inhibit protein synthesis, and is generally bacteriostatic. So tetracycline is a broad spectrum anaerobe gram-negative, gram-positive, multi-resistant organism MRSA, VRE, or infection required deep tissue penetration, nausea, vomiting. We have the chloramphenicol, which blocks the peptidyl transferase at 50S ribosome subunit and is a bacteriostatic, used in the meningitis, in Haemophilus influenza, Neisseria meningitis, and Staphylococcus pneumoniae, rickettsia. Limited use due to its toxicity, used in developing country because of low cost. Side effects of chloramphenicol includes anemia, dose dependent, aplastic anemia, dose independent, and Graves syndrome in premature infants because they lack liver UTP glucononyl transferase. Plasmid encoded acyl transferase inactivates the drug. We have the clindamycin, block peptide transferase translocation at 50S ribosome subunit, bacteriostatic, anaerobe infection, bacteriates, Clostridium perfringens in aspiration pneumonia, lung abscess, and oral infection. Also effective against invasive group A streptococcal infection, treats anaerobe infection above the diaphragm, versus metronidazole anaerobe infection below the diaphragm. Side effects is pseudomonas colitis, fever, and diarrhea. We have the linezolid, inhibits the protein synthesis by binding to 50S subunit and prevent the formation of initiation complex. Linezolid is used for the MRSA and BRE. Adverse effects include bone marrow suppression, thrombocytopenia, peripheral neuropathy, serotonin syndrome due to MAO inhibition, and point mutation of ribosomal RNA. We have the macrolides, which is the erythromycin, clarithromycin, and erythromycin. So it inhibits the protein synthesis by blocking the translocation binding to 23 rRNA of the 50S ribosome subunit and is a bacteriostatic. Macrolides causes clinical use in atypical pneumonias, STDs like chlamydia, and gram-positive foci like the streptococcal infection in patient allergic to penicillin and pertussis. Side effect of macrolides is the pneumonic macro, M for motility issue of GI, A for arrhythmias caused by prolonged QT interval, and C is cholestasis, and R is rashes, E for eosinophilia, increased serum concentration of theophylline, and oral anticoagulation. Erythromycin inhibits the cytochrome P450. Macrolides methylation of 23 as RNA binding site prevents binding of the drug. We have the polymyxin, which is colistin, polymyxin E, and polymyxin B. Cationic polypeptide binds to the phospholipid on the cell membrane on gram-negative bacteria, disrupts cell membrane integrity and leakage of the cellular component cell death. Salvage therapy for multi-drugs, gram-negative bacteria like P. aeruginosa, E. coli, and potassium pneumonia. Polymyxin B is a component of triple antibiotic ointment used for superficial skin infection. Side effects is nephrotoxicity, neurotoxicity, slurred speech, weakness, paresthesia, and respiratory failure. So next we have the sulfonamides. Sulfonamides is sulfamethoxazole, sulfsanazole, and sulfadiazine. Inhibits the dihydroapatite synthase, thus inhibiting the folate synthesis, and is bacteriostatic, bactericidal when combined with trimethoprim. Used for gram-positive and gram-negative, nocardia, TMP-SMX for simple UTI. Adverse events of hypersensitivity reaction, hemolysis, G6PD, nephrotoxicity, tuberculosis, nephritis, photosensitivity, Stevens-Johnson syndrome, chronic stress if infant displays other drugs from albumin like warfarin. So the mechanism of resistance is altered enzyme, bacterial dihydropterate synthesis and decrease of or increase PABA synthesis. So PABA and pyridine is converted to dihydropteridine by dihydroterate synthesis, and dihydroterate synthesis is blocked by sulfonamide and dapsone. Now the dihydroteric acid is converted to dihydrofolic acid, and dihydrofolic acid is converted to tetrahydrofolic acid by dihydrofolate reductase, and this enzyme is inhibited trimethopyrin and pyrimethamine. Tetrahydrofolic forms the purine, thymidine and methionine. Purine forms the DNA RNA, thymidine forms the DNA, and the methionine forms the protein. So dapsone is similar to sulfonamide but structurally distinct agent used in the leprosy, lepromatous and tuberculosis, pneumocystis cerevisiae prophylaxis or treatment when used in combination with TMP. So side effect of dapsone is hemolysis if this is very deficient, same as the sulfonamide, and methemoglobinemia and granulocytosis. Dapsone also causes methemoglobinemia and granulocytosis. Now we have the trimethopyrin, which inhibits the bacterial dihydroterate reductase, bacteriostatic, used in combination with sulfonamide. Trimethopyrin TMP-SMX causes sequential block of folate synthesis. Combination used for UTI, Shigella, Salmonella, pneumocystis cerevisiae, pneumonia treated, and prophylaxis, toxoplasmosis prophylaxis. So adverse effect includes hyperkalemia, high dose, megaloblastic anemia, leukopenia, or granulocytosis, which may be avoided with co-administration of leucovorin, which is a folinic acid. TMP treats marrow poorly. So we have the next fluoroquinolones: ciprofloxacin, norfloxacin, oxafloxacin, respiratory fluoroquinolones like gemifloxacin, levofloxacin, and moxifloxacin. So we have the respiratory fluoroquinolones known as gemifloxacin, levofloxacin, and moxifloxacin. So inhibits prokaryotic enzymes topoisomerase 4, A2, and topoisomerase 4. It is a bactericidal, must not be taken with antacids. Gram-negative rods of urinary tract and used to treat gram-negative of urinary tract, GI tract, including pseudomonas, and gram-positive organism otitis externa. Advocate GI upset, superinfection, skin rash, headache, dizziness. Less common, can cause leg cramp and myalgia. Contraindicated during pregnancy or breastfeeding in infants less than 18 years due to possible damage to cartilage. Some may prolong QT interval, may cause tendonitis or tendon rupture in people greater than 60 old, and in patient taking prednisolone. Ciprofloxacin inhibits cytochrome P450. Mechanism of resistance is chloroform encoded mutation in DNA guides, plasmid mediated resistance, and efflux pump. Next we have the daptomycin, which is the lipopeptide that disrupts the cell membrane of gram-positive cocci by creating a transmembrane channel. Daptomycin used for S. aureus skin infection, especially in MRSA, bacteremia, and endocarditis and VRE. Not used for pneumonia. Daptomycin is used for skin infection but can cause myopathy. So adverse effect is myopathy and rhabdomyolysis. Metronidazole form toxic free radical metabolite in the bacterial cell that damage the DNA. Bactericidal and antiprotozoal. Treats Giardia, antimicrobial, trichomonas, Gardnerella, anaerobes like bacterials. Clostridium difficile can be used in place of amoxicillin in aspiratory triple therapy. Adverse effects is disulfiram reaction, severe flushing and tachycardia and hypotension with alcohol, headache, metallic taste. Okay, and treat anaerobes infection below the diaphragm versus clindamycin anaerobes infection above the diaphragm. So next is